Dear Chair, dear audience, let me present my PhD thesis, Functionality and Aesthetics in Plastic Surgery. My name is Péter. I'm a final year medical student and a first year PhD student. My vision is maximize patient health and satisfaction in the field of plastic surgery. And I want to achieve this by identifying and implementing the safest, most effective procedures. To this end, we have two projects. The first one is comparing the efficacy of different treatments for the treatment of keloid scars. So let's start. This is a systematic review and network meta-analysis. When we think about wound healing, we can imagine it as a spectrum, and on one end we have healing without a scar, also known as regenerative healing. In the middle we have normal scarring, and on the other extreme we have pathological scarring. And keloids are a type of pathological scar. Just in general, scars are fibrous tissue that replaces normal skin after injury. And as we know, several million people each year undergo surgery, and most surgeries leave a scar. And according to some estimates, up to 60% of surgical scars can develop into pathological scars, and the figure is even higher in burn victims. So the two most common type of pathological scars are keloids and hypertrophic scars. Both are the result of excess collagen, but their extent and their histology are distinct. Keloids, the main difference between them is keloids extend way beyond the original wound edges, and keloids are usually treated more aggressively compared to hypertrophic scars. Besides the cosmetic concern that they look quite unsightly, they can cause functional symptoms such as itching or pain. And although we have many options to treat them, there's no consensus on which one to use. So our aim is to assess which of the treatments leads to the best cosmetic and functional outcome. Our clinical question is then, which treatment option is best? Our patients are patients with keloids. We have various scar treatment modalities, and we are going to assess the scar improvement by validated scales. The two most common of these are Vancouver Scar Scale and the so-called Patient and Observer Scar Assessment Scale. What you need to know about these is the higher the score, the worse the scar. So we are looking for lower scores. Our hypothesis is that the combination of therapies leads to better results. And the clinical implication would be an evidence-based decision-making in scar therapy. Here's our flowchart of selection, and here's my first graph. It's a network plot, which basically shows us the available data. These are available studies that used the Vancouver Scar Scale. The nodes represent the treatments, and the size of the node represents how many patients we had for each intervention. As you can see, steroids was the most populous of the groups by far, and the lines connecting the treatments represents the number of studies that used that have a direct comparison between these. So for example, steroids and vitamin D have 3 studies that compare these directly. And here is our forest plot. Our outcome was the mean difference, and given that this is a network, we have to compare them to one treatment, and that treatment was steroids. So, for example, anti-proliferative treatments have a mean difference of minus 2.76. This means that, on average, these treatments reduced the Vancouver score of the scars by 2.76 more. So it was a 2.76 score reduction compared to the steroids. And you can also see that unfortunately, the only significant, statistically significant result we have here is that anti-angiogenic treatments are worse than all of the others. And here is a so-called B score, which is also unique to network meta-analyses. Although we had no statistically significant results barring the one about the anti-angiogenics, we can still make a kind of a ranking between these based on a probability. And the p-score is from 0 to 1, with 1 being the treatment that is the most likely to be the best one, and 0 being the least likely to be the best treatment. And as you can see here, once again, anti-proliferative treatments seem to be the best option at this point. Here's our progress. And for my second project, we are going to look at quite a similar data, but this time regarding hypertrophic scars. Our clinical question is which intervention is the best for the treatment of these scars. We have patients with these scars. Again, many various treatments, and we are also going to look at the scar improvement here using the same scales. And our hypothesis, once again, is that combination treatments are superior at treating these scars. Yes, here are some key articles just to illustrate how many different treatments we have. For example, extracorporeal shockwave therapy, laser devices, silicone sheeting, and also some exotic ones like onion extract. Here's our flowchart of selection, and we have just finished the data extraction for this topic. In summary, we have 2 projects. Both are concerning pathologic scars, and also both are network meta-analyses. One is about keloids, and the other one is about hypertrophic scars. And I would like to close with a quote from Niccolò Machiavelli, where the willingness is great, the difficulties cannot be great. Thank you all for your attention.
Thank you. In one of your last slides, you mentioned pulse diode and yttrium lasers. Do you have any data about CO2 lasers? Here, yeah.
This one? Yes, we also have. I mean, we have many different articles with many different interventions. We have CO2 lasers as well.
And is it useful, not useful?
We don't have the results for the second article yet.
Okay. Have a look on this.
Thanks.
Thank you.